Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us. Good morning, Thursday, July 9th. Thanks for joining us for the Wild Health podcast and COVID update. As of this afternoon, Worldometer reports over 3 million cases and 134,000 deaths in the U.S. and 12 million cases and 547 deaths worldwide. Data from the Financial Times shows a sustained increase in coronavirus deaths over the past few weeks. Currently, the rolling weekly average of daily coronavirus deaths has remained around 4,500. Now, globally, the pandemic continues to accelerate, with the major epicenters being Asia, North America, and South America. After the United States, the largest outbreaks are in Brazil, then India, then Russia. Brazil is the only other country other than the United States to have over 1 million confirmed cases. And interesting there, I don't know if you saw the news, Mike, after months of downplaying the pandemic, their president, Bolsonaro, he tested positive after having some symptoms earlier this week. So it'll be interesting to see if their response changes or not in any way. Here in the United States, we have definitely hit some grim new milestones, over 3 million confirmed cases. Cases are rising currently in 37 states, and it's starting to really have an effect on the infrastructure as well, kind of like we were seeing in New York in the beginning. There are over 40 hospitals in Florida that have run out of ICU beds, and Arizona is on a similar trajectory. I talked to one of our common friends, Mike, that works in the ER in Arizona the other day, and it's just really putting a strain on their system. They're working a lot, they're running out of resources, and it's shocking to me that this is happening again. Like, we saw it happen, and we knew it was probably going to happen in other places if we didn't change things, and now it's repeating, like history is repeating itself. Usually it's not this quick that history repeats itself.
Usually it takes years, not months or weeks.
Yeah, we usually have a slightly better memory than weeks, but yeah, it's repeating itself in some places in the U.S. So testing crises, which were a problem initially, have definitely reemerged as well. There's a shortage of testing supplies, there's backlogs at labs, and the rapid increase in cases has caused some cities like San Antonio and Austin to reinstate a lot of the testing restrictions so that tests are limited to symptomatic individuals in those places. New York City, which we mentioned a minute ago, which has faced one of the country's most severe testing shortages early in the pandemic, they've really increased their testing capacity, so they're doing about 30,000 tests a day. They began building their own testing kits and partnering with private labs, and they hope that that's really going to help there, and it probably will. Hopefully they'll have some capacity for the rest of the country as well. In interesting timing news, the Trump administration yesterday announces that the United States will formally withdraw from the World Health Organization effective July 2020 in the midst of a global pandemic. So we've been making this threat for a little while, and now we've actually started the official progress. The announcement drew immediate condemnation from public health experts and leaders around the world who warned that obviously such a drastic move will undermine the WHO's ability to respond to the pandemic. And what we have to remember right now is that we are the epicenter. So as we are defunding the World Health Organization, who has a big role to play in controlling this, we're the ones with the most out-of-control pandemic. The White House announced a $1.6 billion deal with Novavax, a Maryland-based vaccine company, to produce 100 million doses of a vaccine by early next year, assuming that the vaccine is shown to be effective in clinical trials. This company, I was a little surprised when I read this news, just because this company has never brought a product to market. So hopefully it'll work out. There are also 6 other pharmaceutical companies that have received federal funding and about $4 billion of investment right now from the federal government into various technologies to prevent and manage COVID-19. So hopefully all this extra spending will definitely lead to an increased time frame and an increased speed, which will get this vaccine hopefully this winter. But personally, I still think that's a very optimistic goal, no matter what's being reported in the media at the moment. In a press briefing on Tuesday, scientists from the WHO acknowledged the possibility that the coronavirus may spread via airborne transmission and not just via droplet transmission. This was after 239 scientists from around the world wrote an open letter to the WHO urging the agency to update its guidelines on virus transmission to incorporate the mounting evidence, what I would say is overwhelming evidence at this time, that the virus is spread through airborne particles. It's really important distinction to make because it increases the risk of outbreaks in crowded indoor spaces with poor ventilation. And although some people would say the evidence is inconclusive, like we've said on this podcast many times, all evidence is inconclusive. We never know for sure, but at this point, it seems really, really, really high likelihood that it spreads in this route via airborne transmission. And it's just really important that people know that when they're thinking about what to do, like not spending a lot of times indoor with people outside of their kind of quarantine circle who they're going to be around. And this is going to be really important for schools as they start back, nursing facilities, and then other businesses as well as they're kind of making their plans and how they're going to do this. They may want to consider adding certain types of air filters and UV lights to their infrastructure, but at least knowing this and having a consistent message is important. So I'm glad the WHO came out with that statement.
Thanks for all the really positive news there, Matt. I think that maybe I've got 3 articles that I want to talk about. Maybe the first one I'll talk about, given all of the news you just gave us, is the most pertinent, and that's the prevalence of and risk factors associated with mental health symptoms among the general population in China during the coronavirus disease 2019 pandemic. This was published in JAMA July 1st. So what do you think, Matt? Do you think people are a little bit more depressed, more anxious, have a little bit more insomnia, or you think they're generally feeling pretty well?
I think this is a very pointed question. I have the feeling that you're implying that the news I just reported was leading to increased depression too, not just the pandemic. But yeah, there's a lot of bad news out there. A lot of people, when you add the bad news and the fear that's associated with it and all the unknowns, I got to believe people are at higher increase of depression and anxiety right now.
Yeah, how about, so in these provinces in China, 27.9% symptoms of depression, 31.6% symptoms of anxiety, 29.2% symptoms of insomnia. Does that sound about normal for you, or does that seem higher than normal? Maybe you could ask your wife. She's right there with you, right?
She is, but she's driving. I'm riding, so I'm not going to ask her. Yeah, that's really high. That's really scary. And it's sad, too. And we're kind of joking about this, but this is a really big problem, and it's going to be a problem that we're dealing with for a while. We just talked about the vaccine and how when we get the vaccine, we think this is kind of quote-unquote over, but these are the effects that are going to be lingering for quite a while. And my wife, Chris, and I were having this discussion just about the kids going back to school, and we even, our older ones, great, they're going to go back. They're 8 and 10. They're going to do social distancing. They're going to be wearing masks. We're looking at the plan that our school has in place. But our 2 and 4-year-old, they're getting ready to turn 3 and 5. They're going to be in kind of preschool and kindergarten, and we're probably maybe not even going to send them this year. I'm concerned that a 3-year-old, for example, sure, they learn some things at school, but I don't know, the psychological impact of not being able to touch other people, of not being around. I'm just imagining teachers and others constantly separating kids, and this like hypervigilance around 3 and 4 and 5-year-olds being around each other and controlling that, the impact that's going to have on them. We're considering our current 2 and 4-year-old just keeping them home this next year just because we're worried about that. We haven't made a final decision. It's a very, very personal decision for every family, but there's definitely going to be negative impacts either of kids staying home or kids going with all the restrictions. So I'm worried about our kids long term as well. What's going to happen this
I I am too. We're sort of in the same place, Matt. We're trying to decide what to do with our 4-year-old, and some of it is wanting to keep him safe, wanting to keep our family safe, but then also you balance that with socialization and the ability for him to make friendships. And while he's got a great home life, I would love for him to be able to, at this point in his life, start developing more friendships. And I'm not sure that preschool is the place to do that right now, given what's going on. But at the same time, I'm also conflicted by this concept that, this could be here for a really long time. And at some point, we're going to have to figure out how to go on living our lives and interacting socially with people in a safe manner. And I think everybody kind of has this hunker down, wait it out mentality when, in the reality, it may be something that we live with for an extended period of time, and we have to somehow come to terms with that and figure that out. But I mean, I'm not trying to make light of this situation. I'm joking, only in the sense that, I think that the findings of this study are expected. This is a very serious situation that is causing a lot of people anxiety, aggravating issues of depression and insomnia. And I think that's really to be expected. And I think we as a human race need to do a better job of understanding that and supporting one another rather than doing things like politicizing, people's comments and getting aggressive on social media and making nasty comments to one another. That stuff's got to stop. People got to treat one another better, because we're seeing, 30% in depression and anxiety in patients, 2 times increases in healthcare workers, 2 to 3 times increases in people with exposure to COVID is what this study's reporting. I mean, these are exceptionally high numbers for depression and anxiety. And if we don't watch it, we're going to lose our humanity and the care that we have for one another. And this is just going to spiral out of control. So with that said, that's my opinion. Sorry if it makes anybody angry or if it sounds too reactionary, but I really do feel that we've got to watch the way that we treat one another.
It's always a good time for empathy and compassion, but way more so right now. I think everybody could use a little more of that for sure. And looking ahead, I think we probably also, as a society and maybe the government leaders, need to start thinking about the funding of mental health projects in the future, just like we're funding research and vaccines right now against COVID. And then we personally, what we're doing at Wild Health is we're actually actively working on some programs around mindfulness and mental health optimization that we're going to be rolling out soon for our patients to try to address this need as well.
100%. All right. Next study, Matt, is interesting because it's a comparison of COVID-19 to influenza, specifically in the risk of ischemic stroke in COVID-19 patients versus patients with influenza. The reason that I talk about this is not because the data is all that necessarily interesting, but there's been just so much talk about how similar COVID-19 is with influenza. So I think it's important for us as scientists to really look at that and say, okay, are these two disease processes really that similar? So this is one study that we have that addresses that. And they looked at around 2,000 people with emergency department visits for COVID-19. I believe this was out of New York, and this was just published a couple of days ago. And they looked at how many of those patients had ischemic strokes associated with being infected with COVID-19, and then compared it to another group of patients, similar size, similar cohort, who had influenza. How many of those people had ischemic strokes? And it basically comes down to around 1.6% of patients with COVID-19 ended up having an acute ischemic stroke. And then if you compare that to 0.2% patients with influenza who had acute ischemic stroke. So obviously a fairly large difference there between COVID-19 and influenza, at least when it relates to your likelihood of having a stroke associated with the disease.
Yeah, you cut out a second earlier, Mike. You said something about there's been a lot of talk about comparing COVID to the flu, and I think I missed when you said the word crazy there, a lot of crazy talk. I think that's what you meant
Yeah.
to say. Because in all seriousness, I continue to hear people say, it's just a bad flu. So, and I was thinking about this the other day and having a conversation with someone. I think I understand where this comes from. So I want to go over just a couple numbers that I just have not heard anybody in the media talk about that I think are a little clarifying. So we see, for example, on CNN, they have the feed of how many people are infected and how many deaths. Like in the U.S., they'll say, okay, 3 million deaths and 3 million cases and 130,000 deaths. So we're looking at that and we're like, okay, 4% mortality rate, case fatality rate. Well, we also have all talked about and realized that the probably only about 10% of people who actually are positive and have this virus get tested and are counted among those confirmed cases. So instead of 3 million cases, probably 30 million cases. And the fatality rate, the mortality number, that's probably similar. So the infection fatality rate, how many people that get infected and dies, is much lower. It's maybe 10 times less because 10 times more people have it than are counted. So what that means is that 4% mortality rate it's not 4%, it's 0.4%. So 1 in 250 people instead of 1 in 25 people. And so then you hear people compare that and say, well, that 0.4%, and they'll say, well, the flu, 1 in 1,000 people die, it's 0.1, so 0.1, 0.4, that's not really much of a difference, is it? I've heard that over and over again, but you're not comparing apples to apples. So the 0.1% for the flu, that is the CFR. So if you want to talk about that 0.1% for the flu, then you have to talk about the CFR for COVID, which is that 4%. Now, the IFR, the infection fatality rate for the flu, never gets talked about, but you can find it. And the reason it doesn't get talked about in the past has not been an important number is because most people, just like with COVID, who have, or SARS-CoV-2, most people who have an infection with influenza don't get tested. Most of us, we get sick, we're home a few days, or very, very mild symptoms, we never knew we had it. So that IFR for the flu, if you look it up, the best estimates of that are 1 person out of every 100,000 to 10 people out of every 100,000. So between 1 and 10 out of 100,000. So a lot less, than the 1 in 1,000 number. So if you compare IFR to IFR, then COVID, SARS-CoV-2 virus, is about 50 to 100 times worse than influenza. So that's a big difference. A disease that is 50 to 100 times worse, when we're talking about how many people die from it, those two are quite a bit different. Now, to play devil's advocate on those numbers and kind of argue against the point I was making, if you are a really healthy person, then that number for the flu, your risk isn't 1 in 10,000. It's probably not even 1 in 100,000. It's probably like 1 in a million. So 50 to 100 times worse if the risk is 1 in a million, well, it's still not that bad. So just to be clear, people who are young and healthy, like we've been saying all along, you're not at super high risk. But then when we start to look at things like the stroke risk, even if we don't die from it, that 1.6% blended rate, 1 in 16 having a stroke is pretty high. And again, that is probably lower for young people as well. So I'm going back and forth between saying it's 50 to 100 times worse than the flu, but some people are at lower risk, because I don't want to get lost in these numbers, but I also think it's such a waste of words when we say, oh, this is really bad, or this is not that bad. And I do want to try to put some numbers on it for people so that they can assess the risk. I had a friend of mine text me the other day and said, I'm thinking about flying to this place for a trip. Should I do it? And so I broke it down for them and said, hey, if you fly, I think your chance of getting the virus is this. If you get the virus, I think your chances of having long-term lasting effects is this. If you get the virus, I think your chance of dying is about this, based on your age and comorbidities. And laying out the risk like that, then he was actually able to look at it and say, you know what, the benefit of this fishing trip is not as high as my risk of having some long-term thing from this and some complications, and he decided not to go. But having these numbers, even though they're rough, they're different for everybody, having these numbers in our heads, I think people are smart enough to actually take those and start to make some decisions for themselves. So sorry for all the complicated numbers, but hopefully that cleared up a little bit this whole debate around, is COVID just a bad flu or not?
I think that it's really hard for people to conceptualize those numbers themselves, obviously. And I think it's also challenging for physicians to do that math in their head and be able to spit out, what you did for your friend. It makes me think maybe we should build like a what's my COVID risk app or something where, people put in like what they're currently doing and then their risk factors, and then it spits out, their risk of contracting the disease and also of their risk of having a severe outcome from it. That would be really helpful for people. Maybe we should look at that. But the other thing that I was going to say is that the numbers that you mentioned, the 0.4%, may be a little low as well, because there's been quite a lot of chatter in the scientific community that there's been a significant increase in deaths that have not been associated with COVID, so that there's likely a significant number of COVID-associated deaths that aren't currently being counted. And I know that's a very political statement, which is ridiculous, but there is a significant concern that is there as well. So the number might not be 0.4, it might be 0.6, it might be 0.8. Obviously these are things that are challenging to know for sure, but it does certainly illuminate the fact that influenza and COVID are two very different diseases. Your risk between the two is extremely different, just like your risk year to year from influenza is different. Influenza isn't a single disease. It changes every year, and the risk associated with it, the case fatality rate or the incident fatality rate are different every single year. So we got to quit using that terminology. It's a waste, as you said, a waste of words. That was a great description.
Yeah, and whether we're vastly underreporting deaths from COVID or vastly over reporting, which one of those, it just simply depends on which news channel you watch. Right. Unfortunately, because it's argued so vehemently on both sides. So the numbers we're getting are probably pretty similar, and some people would argue it's low, some people it's high, but I think the numbers are clear enough, at least, that COVID is certainly not just slightly worse flu.
How about we end on a happy article, Matt? Sort of happy, I guess.
I didn't know that existed.
Yeah, sometimes. This one came out June 24th, 2020, so a little while ago. I'm just catching it now. It was a small study, effect of colchicine versus standard care on cardiac and inflammatory biomarkers and clinical outcomes in patients hospitalized with coronavirus disease 2019. This is a Greek study. And they were looking at 105 patients who were hospitalized. So these are sicker COVID-19 patients, and they looked at if they gave them colchicine versus a control group to see whether they had any clinical improvement getting the colchicine. And they measured their markers of cardiac dysfunction, which is a troponin. They measured an inflammatory marker, which is CRP, and they looked at their clinical outcome just to see, did they have bad outcomes? Did they progress and have worse disease, basically? Matt, when was the last time you prescribed colchicine for a patient?
It's gout. I mean, that's all we really use it for the most part, right?
Yeah, and pericardial effusion is the other place that you see it used quite a bit. So gout being basically an inflammatory arthritis, colchicine is an anti-inflammatory, and then pericardial effusion, which is where you get fluid around your heart, or pericarditis, where you get inflammation of the pericardium around the heart. That's just the tissue that surrounds the heart. So it's sort of an anti-inflammatory, causes diarrhea. That's another good reason to prescribe it for people, because just about everybody who takes it gets diarrhea. So this is an interesting study. I'm not sure I would have thought of colchicine as a potential treatment for COVID-19, but when you think about this anti-inflammatory, maybe it is somehow decreasing inflammation or viral inflammation surrounding the heart, which could potentially be improving the patient's outcome. So 105 patients were enrolled in this study. They found no significant difference between the troponin levels, so the evidence of cardiac dysfunction, or the CRP, inflammatory markers, but there was a trend towards significance, so suggesting that maybe they just didn't look at enough patients to get a significant difference. What's interesting, though, is that they did have a significant difference when they look at the clinical outcomes. So when you look at the primary endpoint of clinical outcomes, 14% of the people in the control group went on to have progressive disease, whereas only 2% in the colchicine group ended up having progressive disease based on their criteria. So that's a pretty impressive improvement in the colchicine group. I mean, we're talking about a 3 times reduction, relative risk reduction in the likelihood of progression of disease. So I'm encouraged. Obviously, we need more studies. 105 patients is not enough to tell me that I need to be prescribing colchicine to these patients. But when it comes to adverse events, I mean, the biggest one is, and pretty much the only one that I'm really aware of, is diarrhea. So, I'd certainly take diarrhea over progressing to a ventilator or another death or mortality or morbidity associated with COVID.
Yeah, but so a few things. So you look at the title of the study, it's in hospitalized patients, so it's very important to make that distinction. Any medication we prescribe, there's always going to be risks along with the benefits, and in this study, you got hospitalized patients, they're in a high risk situation, so it's going to be a smaller hurdle to get over, that the benefits outweigh the risk in somebody who's already progressing. So whether or not people should be taking this who are just diagnosed and are outpatient is 100% not answered by this study. It's interesting hypothesis that this brings up. Maybe, since it does have low side effects, maybe it could be used for those patients, but we have no idea. This study doesn't answer that question. And also, it's important to point out, just like we always do, I hate kind of poking holes in these studies, but it's important to talk about the caveats and why it may or may not be right. This is a small study. It's 100 people they randomized. And so when we talk about a 3 times difference, if you look at the numbers, it's seven patients having the bad progression versus 1. So that's a big difference. But when you're talking about, let's say you got 100 people and 8 of them total are going to progress, if you just randomly didn't do anything different and just divide them up into 2 groups, you're probably not going to have a completely even split of 4 and 4. One group is probably going to have more. So there's a statistical chance that just randomly the 2 groups may have fallen out like that. Now, this was a statistically significant difference, and that means, by definition, that there's an over 95% likelihood that this difference is real. So it probably is a real difference. But I think it's important to talk about those absolute numbers too, because it's not a really big study.
You make a really good point, Matt. Let me tell you the confidence interval for the odds ratio. So the odds ratio was 0.11 for the colchicine group, and the confidence interval was 0.01 to 0.96.
So it's just barely. So, and Mike's saying that if the confidence interval, if we went over 1 there, we would say this is not. It's not statistically significant. Yeah. So it's it's just barely statistically significant. Now, the barely statistically significant, probably when you look at this, because just the numbers aren't that big. So when I look at this, I believe, looking at this, that there probably is a difference, but in hospitalized patients only. That needs to be repeated in a bigger study to confirm, and it doesn't apply to outpatient folks. Although I'm not saying it doesn't work in outpatient folks, there's no way to make that leap to outpatient people from this study.
It's so hard to create this research so quickly. It's impressive that it's coming out at the speed at which it is, but I mean, I think we've been shown time and time again now, even during this virus, that we have to be vigilant about the scientific method and not jump to conclusions. Otherwise, we find ourselves prescribing people hydroxychloroquine and not benefiting our patients.
Yeah.
So
and
good reminders, Matt.
And it's a valuable study. Like, I don't want to. It's a heroic effort to randomize 100 people that quickly for something like this. So whenever we do talk about these studies and the flaws and the problems, it's not that we're saying people that are doing it are bad. This is great. It's really good to get this information. It's just important to interpret it and know how powerful of a finding it is.
Absolutely. Well, Matt, I've got to go do a results review with the patient, so I've got to run. But thanks for taking the time.
Great, and thank you all for listening.
Thanks for listening to the Wild Health Podcast. If you found it helpful, give us a 5-star rating and write a review on iTunes. It really helps the podcast, and we greatly appreciate it. If you want to be a client or you want to work with us, go to wildhealth.com. Thanks again.